A challenging time for all of us, and especially for patients with Alzheimer's disease, their care providers, and the clinicians who care for people with Alzheimer's disease. You can imagine a situation where someone has difficulty perhaps comprehending the world around him or her in general, and then throw a COVID infectious disease situation on that particular environment, and you have a complicated situation. In particular, people with Alzheimer's disease may have difficulty comprehending what's going on around them. So when we start talking about things like social distancing, wearing a mask, frequent hand washing, they may not understand exactly why we're doing this. Should they be doing it? They may forget to continue to do it, take their mask off frequently.
And the other thing, in my practice, I'm talking to caregivers, partners, loved ones, husbands and wives all the time. And, being stuck in the house for weeks on end and months, it's tricky. There's more agitation, there's more anxiety, and the neuropsychiatric component of Alzheimer's is something that, we really have to manage.
So evaluating a new patient with perhaps Alzheimer's disease being the diagnosis can be particularly challenging at this time. So often we are now using video conferencing or telephone interviews, which are clearly suboptimal.
Generally, patients with dementia and their carers are older. They have less sometimes familiarity with using video and other telemedicine components. We've had sometimes more glitches and more trouble connecting. So oftentimes we've had to actually transition to a telephone.
Of course, conducting an exam, a clinical exam via video is challenging as well. We can do a modified mental status exam, leaving out some parts perhaps that require motor or visual spatial skills. But generally, memory, attention, concentration, language can be assessed reasonably well remotely.
80 to 90% of neurological diagnoses are made based on the history. So there's no issue with telemedicine with taking a detailed history. Understanding progressive short-term memory decline and other changes in sleep or behavior, psychiatric symptoms with other premonitory symptoms and non-cognitive complaints, as well as risk factors for Alzheimer's disease. It's possible to make a reasonably reliable diagnosis of possible Alzheimer's disease. So what we've done is actually we've used a screen sharing software and Zoom. We use Zoom to have the video interview part, and we use a screen sharing software that patients with either minimal cognitive complaints or normal cognition, we've actually redeployed the cognitive test, and we can get about 80–85% of the testing done.
There are certain challenges with assessing visual spatial skills. So having the person draw a box or having them draw a clock can be difficult when you're asking them to do it just verbally rather than having them actually copy a form. You can draw a box, you can draw a clock and show it to them on the video screen, but again, it's a bit more difficult. So if you have someone with moderate disease or severe disease, they may have a great deal of difficulty understanding what the assessment is, what's going on. Of course, many of individuals at that level may also have anosognosia and really not appreciate that anything is wrong with them. Hence, the whole assessment becomes useless to them. So these are issues that compound the problem. There's comprehension, there's ability to pay attention, to concentrate on what's going on.
The other part that's been challenging is, when do you decide to go to the hospital and seek medical care? I have one patient who literally lives 2 blocks down the road that was having a cough and having, it wasn't a fever, it was 99.9. A person with Alzheimer's disease, first of all, he also had other vascular issues. He had high cholesterol, high blood pressure. He had borderline diabetes, even really kind of, early diabetes. This person has multiple medical conditions. And if he goes to the hospital to be evaluated for COVID-19, we have to remember that he will be admitted by himself. There will be no visitors. There will be no advocate for the patient. We had this heart-to-heart conversation. His son was in Dallas and was on the Zoom call. And, we decided collaboratively that until the fever goes above 104, until there was shortness of breath. But the goal is that try to keep the person at home for as long as possible, because the psychological trauma and the disruption in being admitted to a hospital, even for observation, in a crowded hospital with no visitors, with no one to provide, collaborative history. We really struggled. I think in a normal situation, we would have said, go to the ER, go to an urgent care. But a 91-year-old man with moderate Alzheimer's disease, you go to the emergency room and that could be it. So that was a tough one. And we ended up keeping him at home. There's certainly unique challenges that we're coming up with when it comes to COVID-19 and dementia. There's many, but that was one that kind of rings true just recently.